Inspection is very easy. Okay, coming to the last part of the discussion of heart. Murmurs. So first, what is the definition of murmur? Murmur is an abnormal sound which is produced due to abnormal flow through a normal valve, normal flow through an abnormal valve, or flow through abnormal passages. So every word here is important. It is a sound. I left one word. It is a sound produced due to turbulence of blood flow. Remember the word, it is not a heart sound. It is a sound. It is not produced due to valve closure or valve opening. For that only we have discussed S1, S2, clicks, opening snap, etc. So murmur is not a heart sound. It is a sound which is produced due to turbulence of blood flow. So how the turbulence is produced? Due to three reasons. One, a normal flow through a
abnormal valve.
We'll come to the first. Abnormal flow through a normal valve. That is, the valve, everything is normal, but the flow is more. The typical example for this is so-called as hyperdynamic murmur or an innocent murmur, the one we discussed in bicuspid aortic valve. So pulmonary valve is the shortest diameter valve. So increased flow which occurs through this normal valve will produce a murmur. So again I told you the hyperdynamic states are 6 in number. Anemia, fever, thyrotoxicosis, pregnancy, beriberi young adults. These are the 6 causes which are mentioned in Harrison. I'll just mention here. Anemia, fever. Fever causes tachycardia. Tachycardia will cause loud S1. That will be associated murmur also. I'll tell that. Pregnancy, thyrotoxicosis, beriberi. Beriberi is one cause of high output cardiac failure. Remember beriberi. 6th cause is young adults. So even if you auscultate for ourselves, we can hear. These are the 6 hyperdynamic states which can produce a murmur. Okay. So this is called as one category. Abnormal flow through a normal valve. We can add few more also. For example, think of mitral regurgitation or aortic regurgitation, where the regurgitation occurs from the aorta to the left ventricle. Left ventricle becomes large. Now even if a non-stenotic valve is there, a flow through this aortic valve can produce some murmur. All this comes under abnormal flow through a normal valve. Now the second cause of turbulence is normal flow through an abnormal valve. All the stenosis, all the regurgitation. Simple. Third thing is flow through abnormal passages. What are the abnormal passages? AST, VST, PDA. Remember, AST will not cause murmur. AST will not cause a shunt murmur. VST will cause a shunt murmur. PDA will cause a shunt murmur. Simple. As simple as that. So define murmur, it's a sound which is produced due to turbulence of blood flow, either through abnormal flow through a normal valve, normal flow through abnormal valve, or flow through abnormal passages. Okay, so again coming to the initial basic which I told you, whenever you are describing a murmur, you have to tell few things. Whenever you are describing murmur, first most important thing is time the murmur. Okay, initially when you are practicing, time the murmur as either systolic or diastolic. So when we say systolic murmur, any murmur which comes after S1 or any murmur which comes after the pulse will be a systolic murmur. Any murmur which comes before S1 will be a diastolic murmur. Simple. So you are hearing a murmur, pulse comes, diastolic murmur. Pulse comes, then a murmur comes, it is systolic murmur. Simple. Pulse comes, then murmur comes, it is a systolic murmur.
Murmur comes, pulse comes,
diastolic murmur. Simple. Okay. Next you auscultate. Now you will have S2 also. Then it is very easy to communicate because between S1 and S2 we have systole. S2 and next S1 is diastole. Okay. Why I am telling this is, you are timed it. First you are auscultated. The murmur comes after S1, it is systolic murmur. Now you have auscultated S1 and S2 also. If the murmur comes immediately after S1, ends before S2, this is early systole, right? This is called as early systolic murmur. We have few differential diagnoses for this one. This is early systolic murmur. Immediately after S1, ends well before the mid part of systole. This is early systolic murmur. When will a murmur end? What is murmur due to? Turbulence, right? So again, some basic hemodynamics. Normal flow through an abnormal valve means a valve is stenotic or regurgitant. We have two chambers. One is the distal chamber and the proximal chamber. So I'll just put a diagram. Shall I explain with reference to MS? Okay, MS. This is LA, this is LV. We we have two chambers. The proximal chamber is LA, distal chamber is LV. If you understand this basic, doing echo is also very easy. This is mitral valve. This is stenotic. The flow occurs from LA to LV during only one phase. Which is that phase? Diastole. Okay. So flow occurs during diastole. Now, how long the flow will occur? As long as LA pressure is more than the LV pressure, flow will occur. For example, if you think the LA pressure is 60 millimeter, just for an example, LV pressure is 40 millimeter, the flow will continue as long as LA pressure becomes 40, right? Right? But assume a condition where LA pressure is 100, LV pressure is 40. The flow will continue as long as the gradient is more. So it will take a longer time. That is why we say the more the duration of the murmur, more is the severity of the murmur. So how is a murmur produced? Blood flows from the LA to LV through mitral valve during diastole, but there is a stenotic valve, so it produces a turbulence. How long the turbulence will last?
Severe, more severe.
Or in other words, when does flow through the mitral valve begins? Mid-systole, mid-diastole, right? Because that's the phase when mitral valve opens. Not in the isovolumetric relaxation phase.
Yeah.
Mitral valve opens in the mid part of diastole. So only when that opens, flow begins. So the murmur begins when the valve opens. So that starts in the mid part of diastole. How long it continues? It can continue. In case the gradient is very small, it can end before the next S1. It can end before the next systole. If the gradient is more, it can extend even up to S1. But we have another problem in diastole. What is that? Atrial contraction. Even when the flow is reduced, now the atrium is contracting to push the remaining blood, even though there is no gradient into the ventricle. So there is a murmur which occurs. Assume the first example itself, 60-100. Okay, blood flows from the left atrium to the left ventricle during diastole when the valve opens, which starts in mid-diastole. So the turbulence begins during mid-diastole, which is heard as a murmur. So since it starts in the mid part of diastole, we call it as a mid-diastolic murmur. How long does it continue? Till the gradient becomes 0. When the gradient becomes 0 also, we have a problem in this scenario because left atrium contracts. It pumps again blood into the stenotic left mitral valve. So we hear extra another murmur which increases in the late part of diastole. So we hear a mid-systolic murmur. Mid-diastolic murmur, which increases in the later part. That is called as pre-systolic accentuation. Remember, pre-systole means S4, atrial contraction.
Okay.
Now, this is timing. Now, what will be the character of the murmur? LA pressure is initially higher than the LV pressure. When the flow occurs, what will happen? LA pressure becomes 50, the lower pressure becomes 45, for an example. So the gradient keeps on reducing. When the gradient keeps on reducing, the flow reduces, right? So that is how you get the diagram of the murmur or the quality of the murmur. So any murmur in which the gradient reduces over time will something called decrescendo murmur. The intensity reduces.
Pressure gradient decreases,
Intensity reduces. Now I will tell another example. You are going to tell me the mechanism. Understood this concept? So mid-diastolic murmur, why it occurs? Due to opening of the mitral valve during mid part of diastole. It persists as long as there is a pressure gradient between LA and LV. But what is the reason is
since
part
there
is
is
pre-systolic
contraction, it will
aggravate the murmur.
Due to this pre-systolic
Accentuation
occurs.
Pre-systolic accentuation is different from pre-systolic murmur. What is pre-systolic murmur? I told you murmur can continue as long as the gradient is there.
Yeah.
As long as the gradient is there, murmur can continue. So even this part of the murmur can continue till long, even without the contribution from S4. That is called as pre-systolic murmur. This is high tech, but at least now remember mid-systolic murmur with pre-systolic accentuation. When will pre-systolic accentuation be absent? When atria is not contracting, atrial fibrillation. Simple. So understood this. So first important thing is you have to time the murmur. The quality of the murmur will depend upon the pressure gradient. Now I will tell another example. I will guide you in between. You just tell me. This is left ventricle. This is the aortic root which is coming. Aortic valve is stenotic. We have an aortic valvular stenosis. This is left ventricle. Blood is pumping through here. Now tell me the same mechanism. This is LV. This is aorta. The gradient is from
LV
LV
to
iota.
Iota.
So what will be the timing of the murmur?
once opening of the aortic valve.
So it occurs in
mid.
obviously, because aortic valve opens only in the mid part of systole. But the thing is, what will be the, so this is a mid-systolic murmur, right?
Yeah.
Aortic stenosis murmur will be a mid-systolic murmur because aortic valve opens during mid part of systole. How will be the quality of the murmur? There are two ejection phases, rapid ejection phase and a late ejection phase. So initially there will be an ejection, so the pressure rises rapidly. So you'll have a crescendo murmur. It is not that falling trend because it's a high pressure chamber, so it is ventricle is pumping like anything into the aorta. So rather than the pressure gradient falling, the pressure is increasing here actually. So we have a crescendo pattern initially. Then later what happens, late part will be a slow ejection. This follows the decrescendo pattern. Flow is forward, but the gradient starts reducing.
Initially due to
Rapid ejection phase and the high muscular volume of the left ventricle, the initial flow will be a high pressure one. So we'll have a crescendo murmur irrespective of the gradient. The later part will have a gradient. Right? So this is called as crescendo, decrescendo or a diamond shaped murmur. This is how you get the quality. So if you think about the hemodynamics of each and every lesion, we have only MS, MR, ASAR, most common. PS, primary PS, secondary PS, PR, primary PS, secondary PS. If you think about all the hemodynamics, you can get things like this. So understood the basic. First thing is time the murmur as systole or diastole. Then you can have an early systolic murmur, mid systolic murmur, late systolic murmur or a pan-systolic murmur. What does a pan-systolic murmur means? The gradient is present throughout the systole. Occurs in VST. Because left ventricular pressure is high, it pumps all its blood into the right atrium. As long as blood is there, as long as it ejects. Another example is mitral regurgitation. So blood flows into the left atrium from the left ventricle as long as the gradient is there. Gradient will be for a longer time because LA is a very very low pressure chamber. Its pressure is only 5. LV pressure is very very high, it is 120. But we do not get such a gradient in aortic stenosis murmur because aortic pressure is 80, LV pressure is 120. So there is a phase where it can fall. That's all. So time the murmur as systolic, diastolic. Systolic murmur will be early systolic, mid systolic, late systolic or pan-systolic. Okay. Pan-systolic, I told you the gradient will be throughout. So how will be the quality of the murmur? It will be a blowing of equal intensity, blowing murmur. Holosystolic will be a blowing murmur.
Ejection systolic murmur or holosystolic?
Both are same. How will be ejection systolic murmur? I told you it occurs in aortic stenosis. Crescendo, decrescendo. Because of the initial rapid ejection phase. Early systolic murmur will be a decrescendo because there will be it occurs even before opening.
Crescendo, decrescendo is aortic stenosis.
Okay. Early systolic murmur will be a decrescendo murmur. I will tell the causes later. Similar diastolic murmur we have early diastolic murmur. I will tell the causes later shortly. Mid diastolic murmur, the one which we explained now, mitral stenosis.
Early diastolic murmur occurs in which condition?
I will tell later. 1 hour.
Mid systolic is
AR and PR.
Mid systolic is ejection systolic. Okay.
Ejection systolic is also called as mid systolic murmur. Okay, so early diastolic murmur, mid diastolic murmur, we have late diastolic murmur. Some books say we have pan diastolic murmur also. What is systolic or diastolic murmur? One murmur is heard in systole, one murmur is heard in diastole. It is called as systolic or diastolic murmur or a to and fro murmur. To and fro murmur. What is continuous murmur?
PDA.
Murmur begins in S1, continues throughout systole, continues through S2, continues through all or part of diastole. It is called as continuous murmur, occurs in PDA. There are many other causes, I will tell now.
Continuous murmur.
AS with AR, to and fro.
Okay, so you have finished the first part of diastole, right? You should tell what is the timing, systolic or diastolic. Then you have to tell what part of systole, early systole, mid systole, late systole, pan systole. Diastole also early diastole, mid diastole, late diastole. Late diastole is nothing but pre-systolic accentuation, right? Once you have timed the murmur, if you possibly can tell about the quality of the murmur, crescendo, decrescendo, or crescendo, decrescendo, or a blowing murmur, whatever it is. But what does it indicate? It indicates the pressure gradient, right? I'll tell again what are the gradients available. Then after that, we have some special maneuvers For example, some murmurs are better heard in leaning forward position. They are just the theoretical concepts which you should just remember. All the left-sided murmurs are better heard with expression. All the right-sided murmurs are better heard with expression. That we will discuss in dynamic auscultation. They are very easy. So with this concept, we'll finish the last part, the last 10 minutes of our discussion. MSM is also called as ejection systolic murmur. What are the causes? Any ventricular outflow tract obstruction. ASPS. Right, I told you now, just now. Even a dilated aortic root or pulmonary trunk can also produce MSM. This is the murmur which, I won't confuse you now. Dilated aortic root or dilated pulmonary trunk itself can produce ASPS, that is ventricular outflow tract obstruction. Dilated aortic root, dilated pulmonary trunk itself can produce mid-systolic murmur. I told you many causes. Dilated aortic root will produce loud A2, click, as well as mid-systolic murmur. I am discussing
early ejection systolic murmur.
Okay. Now, the most important thing is any condition causing increased systolic flow.
Yeah.
Yes. What are the conditions? Anemia, fever, pregnancy, thyrotoxicosis, beriberi. But actually, two things are there. This is physiological conditions. MR and AR also. MR, AR, PDA, they are hyperdynamic states which are pathological. There is something called as normal murmur or innocent murmur. Remember, hyperdynamic murmur is different from normal murmur. We hear a murmur in newborns which is called as Still's murmur. It has no significance at all. It is called as normal murmur or innocent murmur. Never say if you are hearing a murmur in pregnancy, it is not an innocent murmur. It is a flow murmur. Innocent murmur should not have any pathological significance at all. It should not be due to hyperdynamic conditions. Next important thing is MR due to ischemic heart disease. The one we were discussing with Tamil Selvan sir that day. If you are hearing, actually MR in chronic status should produce a...
That is with not Tamil Selvan sir. That is with whom? Lakshmi sir.
Okay. Okay, if you are hearing pansystolic murmur, it indicates a chronic MR. But acute MR will produce an early systolic murmur because the gradient will come back.
Acute MR may not produce murmur, or if produces, that is
early systolic murmur or mid systolic murmur, right? Okay, just a few points about aortic valve stenosis. I told you it produces ejection systolic murmur, better heard in the right second intercostal space, radiates to the carotid. These are the things you know. Why it is better heard in the aortic space? Because, the first one I told you. Jet is going towards the aortic root. So the murmur is actually produced in the aortic root. It's a crescendo decrescendo configuration because of the LV aorta pressure gradient difference. Okay. In this murmur, three effects you have to remember. One is Gala-Warden phenomenon, post extrasystolic potentiation, and Coanda effect. Coanda effect. This is given only in Perloff.
Okay.
Okay.
Balloon.
Okay. Balloon, everything is given. Okay. What is Gala-Warden? Again, I think we discussed this that day. In a case of calcific aortic sclerosis or a calcific aortic stenosis, the flow through the valve will produce some vibration. A part of the vibration will be transmitted to the aortic root. The high frequencies will be transmitted to the left ventricle. I told you any event in the left ventricle will be better heard in the apex. So we hear low frequency sounds in the aortic area, high frequency sounds in the apex. So this dissociation is called as Gala-Warden dissociation. So harsh basal murmur due to turbulence in the aorta and a high frequency or a shrill murmur or a musical murmur in the apex. Why you should know this Gala-Warden phenomenon? It indicates calcific AS.
Oh.
Okay, it is not for a theoretical purpose. If you are demonstrating Gala-Warden phenomenon, it indicates it is a calcified valve. Calcific aortic stenosis.
What happens in calcified valve?
In calcified valve, the vibration capacity will be different. So it vibrates differently, the valve. A part of the vibration will be transmitted away from, beyond the aortic valve. A part of the valve will be reflected, but that's all.
It's like a hitting wall, calcified wall.
The mechanism we discussed for ejections sound, cephalad, doming, the same thing. Okay, this is one effect, Gala-Warden phenomenon. So why to know Gala-Warden phenomenon? It indicates calcific. We have another thing called as PEP, post extrasystolic potentiation. Why it comes is, in Gala-Warden phenomenon, the murmur will be loud, murmur will be better heard in the mitral area. Any murmur in the mitral area will obviously think of mitral regurgitation. So we should not get confused between ADS murmur which is transmitted to the apex or a mitral regurgitation murmur which is getting transmitted to the apex. So if you are to have one test, that test is called as post-extrasystolic potentiation. So why this post-extrasystolic potentiation is different is we have to differentiate Gallaward and MSM from pansystolic murmur or any systolic murmur of MR. Mid-systolic murmur of
post-extrasystolic potentiation.
Post-extrasystolic potentiation. What is extrasystole? If there is a ventricular premature contraction, we have a long pause after that. The beat which comes after that will produce a loud sound. So the murmur increases in intensity after a extrasystole. It is called PEP, post-extrasystolic potentiation.
After premature.
If you demonstrate this phenomenon, it is AS. It is not MR. Okay. This thing I saw only once in a patient. I took a general clinics case for the case in our unit, and that patient died, you remember? This patient had aortic post-extrasystolic potentiation.
How? Based on ECG only?
Extrasystole will produce a regularly irregular pulse or an irregularly irregular pulse. So if the heartbeat is irregular, after an irregular beat, you will hear an increased murmur. Or if you don't want extrasystole, I will tell with AF itself. AF will have short cycles, long cycles. Following long cycle, the murmur will be aggravated. That's all. So following an extrasystole or following long cycle of AF, if the murmur aggravates, it is called as post-extrasystolic potentiation. It is AS. So you should know post-extrasystolic potentiation to prove that this is AS. You have to know Gallaudian phenomenon to prove that it is calcific AS.
After short cycle of
Short cycle of AF, long cycle of AF. After long cycle of AF, murmur aggravates because of increased flow. This question was asked last year to Srinidhi ma'am during her exam. Since she answered it, she was given full marks, maximum marks. Okay. Coanda effect is nothing. I told you aortic stenosis murmur conducts to the aorta, carotid. If you are hearing only the carotid murmur and not hearing the aortic area murmur, it is called Coanda phenomenon.
What? Once again.
In aortic stenosis, murmur occurs in the aortic area. It gets conducted to the carotid. If you are hearing only the carotid murmur, but you are not hearing the aortic murmur, it is called as Coanda effect. It occurs due to vascular constriction. That is called as supravalvular AS. So you should know Coanda effect to say that it's a supravalvular AS. Name one condition causing supravalvular AS, Williams syndrome. So just by these three effects, we can tell the etiology. We can tell whether it is we can tell it is congenital AS by one finding. What is that? Bicuspid aortic valve. Ejection click.
Yeah.
So presence of click and AS means it is congenital. Absent A2 and AS murmur, it is calcific AS. Presence of Gallaudian phenomenon, it is calcified. Presence of PEP confirms, post-extrasystolic potentiation confirms AS. Presence of Coanda effect, it is supravalvular AS. Now we have another one thing, HOCM, subvalvular AS. I'll tell that shortly. Okay, so this finishes aortic valve stenosis. Now pulmonary valve stenosis produces a murmur in the pulmonary area. That is again simple, nothing much more. Dilated aortic root or dilated pulmonary root. As in AST, we discussed the causes recently. Pulmonary hypertension, AST, hyperdynamic states will produce ESM. So we discussed that also. In pulmonary area, if the murmur is more, it is hyperdynamic murmur. Innocent murmur, it occurs without any pathological significance. Just know the names. One of the important murmur is a Still's murmur. Still's murmur occurs in the right ventricular murmur. So this finishes one thing. Still's murmur occurs in newborns or infants. Heard between apex and tricuspid area. It has medium frequency tones. That I think you can read. It has nothing much clinical significance. Maybe heard in thin individuals also. Okay. So if at all someone asks you aortic stenosis murmur, remember Gallaudian Coanda's effect.
Post-extrasystolic potentiation.
Okay. Never forget this. Okay. Pansystolic murmur. We have finished one murmur. Now come to pansystolic murmur. Chronic primary MR. Term is self-explanatory. It is not acute MR. Chronic primary MR. What is secondary MR? MR which is produced due to dilatation of left ventricular cavity in left ventricular failure.
Secondary MR?
This is PSM. MR is of two types.
Primary MR.
Primary MR, secondary MR.
Secondary is due to?
Primary is due to problem with the leaflet coaptation. Secondary MR, the annulus dilates, the left ventricle dilates, so it pulls the valve along. Example, ischemic dilated cardiomyopathy, ischemic dilated cardiomyopathy. In that case, you will not hear the murmur at all. It is one of the causes of silent MR. So secondary MR, chronic secondary MR will not produce a murmur. You would have seen many patients, they'll be saying dilated cardiomyopathy, mild MR, but we won't hear murmur. It is silent MR. So secondary MR is silent MR.
Ischemic heart disease, dilated cardiomyopathy, left ventricle failure.
Why it is silent? There is no gradient at all. Left ventricle is not contracting, so how can blood flow? So there is no turbulence at all. But primary MR, left ventricle is normal. And chronic flow will dilate the left atrium. So we have a chronic pressure gradient between left ventricle and left atrium, which occurs throughout the systole. So it begins with S1, ends till S2. I told you initially also, it will cause absent S1. Okay. So MR is over. Next is TR. Again, note the term, it is functional TR. TR is of two types. Primary TR, secondary TR or functional TR. What is primary TR? Everything is normal. The tricuspid valve leaflets are not coapting. It is called as primary TR. Secondary TR, functional TR means patient is having MS, patient is having pulmonary hypertension, patient is having right ventricular hypertrophy. Because of that, there's an increased pressure in the right ventricle. Right? Now, because of this, ventricle contracts and it pushes the blood into the right atrium. This is called functional TR. So, two types of TR are primary TR, which occurs in the normal, low pressure, right-sided circulation. Whereas functional TR occurs with pulmonary hypertension and a high right-sided pressure. So, which will have a longer murmur?
Functional.
Yes. So, functional TR will produce a PSM, whereas primary TR will produce an early systolic murmur. So, if you are hearing a murmur in the tricuspid area, please note henceforth this one. Whether it's a PSM or it is an early systolic murmur. If it is an early systolic murmur, it is primary PR. You need not do echo, you need not do Doppler, you need not do catheterization.
In primary, the valve is normal.
Valve is abnormal. The other things are normal. Valve does not coapt. Pulmonary pressure is very low. Valve does not coapt. It does not come together. But you know the pulmonary pressure is very, very low. Only 25 millimeters of mercury. So do you think 25 to 10 pressure will cause much gradient? So the gradient reduces very fast. So we will hear only an early systolic murmur in primary PR, whereas here the pressure is very high. The right ventricular pressure itself will be more than 70 or 80. So the pressure will be high, so it causes a PSM. So PSM 1 is chronic primary MR, next is functional TR, then your most favorite diagnosis is restrictive VST. You have been telling VST 4 times till now. Not non-restrictive VST. Non-restrictive VST occurs in tough.
The cause for PSM.
PSM.
Is MR, T.
Chronic primary MR. Wordings. After this class, you should say only chronic primary MR.
Chronic
and functional
primary
TR.
MR, secondary
Functional TR. And restrictive VST. Y means in TOF we have non-restrictive VST. There is no flow, there is no pressure gradient at all. It flows easily. So in restrictive VST, we will have PSM. What is that murmur called? Malady D. Roger murmur. A very small muscular VST is called as Malady D. Roger syndrome. I will write. Malady D. Roger syndrome. A very small muscular VST will produce a very large murmur. That murmur is called Malady D. Roger murmur. This is important because
very small VST.
Very small VST. If you are hearing a very obvious murmur in a young patient, we saw one patient in our OP, remember? He had a very obvious pansystolic murmur due to VST. Then we can be happy because he will not go for asymmetricization. Because a small VST will restrict some amount of the pressure. He will never go for asymmetricization. Whereas an echocardiographically detected VST with no clinical manifestation is dangerous because it's a non-restrictive VST. He will be having a large left to right shunt, more amount of asymmetricization. Okay, so this is a paradox. I will tell everything only in a clinical thing. So this is highly clinical. So chronic primary MR, functional TR, restrictive VST. If you say VST, you have to always tell about PDA. PDA with the pulmonary hypertension. PDA produces continuous murmur. PDA with pulmonary hypertension will cut off the diastolic component. If there's connection between aorta and pulmonary artery through patent ductus arteriosus, it is PDA. If the connection occurs between aorta and pulmonary artery through any other connection, it is called aorta pulmonary window. Congenital heart disease. So PDA or aorta pulmonary window with the pulmonary hypertension. Because aorta pulmonary window produces continuous murmur. Okay, so what are the 4 causes of PSM? Chronic primary MR, functional TR, restrictive VSD, PDA or aorta pulmonary window with the pulmonary hypertension. Now another important thing is radiation. We all know there are two leaflets of mitral. One is anterior mitral leaflet or posterior mitral leaflet. If the anterior mitral leaflet is regurgitating, A for A, anterior mitral is regurgitating, the murmur radiates to the axilla. A for A. Not only to the axilla, if the anterior mitral leaflet is prolapsing, the murmur radiates to the axilla, left scapula, vertebral column, even cervical spine, even lumbar spine.
Axilla, left scapula.
Spine, from cervical to the lumbar spine. Posterior leaflet will radiate to the base, simple, to the aortic area and to the neck. The jet will be opposite. So anterior leaflet radiates to the axilla, back. Posterior leaflet radiates to the base or aortic area. This is the problem because you may tell clinically by telling pansystolic murmur in the mitral area, so it is a MR. But what will you think? We'll always look for a conduction to the axilla. If there is no conduction to the axilla, also MR is possible if the posterior mitral leaflet is prolapsing.
Okay.
Name yet another condition which produces posterior mitral leaflet prolapse. Mitral valve prolapse. Posterior leaflet is the commonest valve to prolapse in the MVP. So in MVP, even though there is mitral regurgitation, you will not hear the murmur in the axilla, you will hear the murmur in the aortic area. Here only the role of post extrasystolic potentiation comes. Only two area murmur is heard. Okay, post extrasystolic potentiation we have discovered. What is carbolocine?
Carbolocine, inspiration, expiration.
Inspiration will aggravate murmurs of the right side. Actually, TR murmur aggravates on inspiration. That is specifically called as carbolocine. The full form of carbolocine is rivarocarbolocine. Rivarocarbolocine.
Okay.
So if some... Okay, so if someone says carbolocine, always say it is TR murmur. But we colloquially use it for any right-sided murmur. Carbolocine murmur will disappear with right ventricular failure. Because there's nothing to regurgitate. It won't contract at all. I told you already, pulmonary hypertension, when it goes for failure, split widens. So just by auscultation with a wide split and absence of carbolocine, we can tell that patient is going in for a right ventricular failure. Okay, right. Why I told this carbolocine is it differentiates MR from TR. If you are auscultating randomly and if you want to differentiate MR from TR, carbolocine. So PSM, chronic primary MR, functional TR, restrictive VST, PDA or aortopulmonary window, pulmonary hypertension. What are the effects here? Again, post extrasystolic potentiation, axillary radiation, basal radiation, rivarocarbolocine and failure. Okay, two important murmurs are on. Now just note down what are the early systolic murmurs. Acute MR, accepted? Primary TR, accepted? I told the hemodynamics now. Very small VST may produce early systolic murmur because the VST closes in the mid part of systole. Malady reservoir may produce an early systolic murmur. Non-resistive VSD with the pulmonary hypertension. With pulmonary hypertension, always remember murmur disappears. So in the early part of pulmonary hypertension, a pansystolic murmur will become early systolic murmur. Then it will disappear. The disappearance marks asymptomaticization. Okay. Now, late systolic murmur, only one condition. What is that? Mitral valve prolapse. After the mitral valve prolapse occurs in the late part of systole, it produces a non-injection click. It's a late systolic sound. So the systolic sound comes, mitral valve prolapse occurs. Okay. Now just one basic thing before we finish. I told you all left-sided murmurs will increase with expiration. All right-sided murmurs will.
That's the question.
That's the question. Except.
HOCM and MVP.
That is any condition which reduces flow to the particular ventricle will reduce the murmur. So standing. Okay, standing. Then first phase of Valsalva will reduce blood flow to both right side of the heart and left side of the heart. So all murmurs decrease except mitral valve prolapse. So you can see some YouTube videos for this. They'll be giving some diagrams. When blood flow reduces, the prolapse will be more. So murmur will occur early. So that's what I have mentioned here. So in mitral valve prolapse, it is introduced by click. Only two maneuvers, standing and Valsalva maneuver. The murmur will lengthen and the murmur softens.
Okay.
Opposite to what? Please remember, lengthening is the word. Other murmurs will decrease. This murmur lengthens, but it softens.
Okay.
Click occurs earlier. Squatting, passive leg raising, hand grip will have the same effect. Okay, just note it down. I think you can understand that. I'll just finish the remaining. Arterial murmur, I won't say. Early diastolic murmur. Now systolic murmur is over. Now diastolic murmur. Early diastolic murmur only two, AR and PR. Now this is a very common question. We have Erb's area, which is left third intercostal space. We have aortic area, which is right second intercostal space. I told you aortic root is in the right second intercostal space. Aortic valve is in the left third intercostal space. So if the aortic valve is regurgitating, you will hear early diastolic murmur in the left third intercostal space or in the neo-aortic area. If the aortic root is regurgitating, as in Marfan syndrome, you will hear the early diastolic murmur better in the right second intercostal space. This alone is enough. Now another one word if you have to remember about AR, Austin-Flint murmur.
Once again, aortic valve is neo-aortic area. Next one is
Austin-Flint. Early diast. That is MDM which is heard in AR. It's called Austin-Flint murmur. This again we will discuss in the MDM. Okay, I'll tell about MDM now. There are 8 to 9 or 10 causes of MDM. MS, which we discussed now. MS or the counterpart is TS. Then I told you, even with a normal mitral valve, any increased flow through the mitral valve can produce functional MS, that is called. So any regurgitation, any AR, any MR, any left to right channel like VST PDA can produce flow MS. Flow MS means mid-diastolic murmur will be heard, but valve size will be normal. Don't read the fourth one. Read fifth one, complete heart block. That is complete heart block, that is AV dissociation. Based on where the contraction occurs. For example, if the atrial contraction coincides with the rapid filling phase, mitral valve will open, right? That is atrial contraction occurs during the first filling phase. So we'll hear a murmur. Next is acute severe AR. What is that called? AR la varakodiya MDM is called as Austin-Flint murmur. Just now we told. Acute severe AR, Austin-Flint murmur. What is the mechanism? Here what happens, more amount of blood comes from the aorta into the left ventricle. It is closing the mitral valve prematurely. So you will have a flow MS.
Once again,
aortic regurgitation, more amount of blood is coming from the aorta to the left ventricle. It prematurely closes the mitral valve. So you will hear MS now.
Okay.
In primary PR also you can hear, similar to AR. AR you can hear, PR you can hear. Closest DD for MS is left atrial or right atrial myxoma or a thrombus. Myxoma, left atrial myxoma will mimic. This is one question for you. What's the closest DD for MS? Left atrial myxoma. But myxoma will produce a tumor plop rather than opening stamp. That is one thing of difference. Okay, you know very well, MDM murmur is augmented by exercise and cough. What happens in AF? Pre-systolic accentuation is lost. Okay. How to differentiate flow MDM in tricuspid area and mitral area? This is the, again, if you remember this thing, MR is going to cause S3. MR can cause flow MS.
MR will cause
A predominant MS plus MR is there. That is, you are hearing a mid-diastolic murmur. You are hearing a pansystolic murmur. I can substantiate that the mid-diastolic murmur which I am hearing, it could be due to a flow MS rather than a pure mitral stenosis. So how to differentiate that? Presence of S3. Yes. Presence of opening snap means it is an organic MS. So Austin-Flint I told you. This finishes mid-diastolic murmur. So just know the causes, mechanisms. Okay, again, late diastolic or pre-systolic murmur causes. TS with sinus rhythm. Because presence of sinus rhythm, atria can contract. In AF, this pre-systolic murmur is lost. So TS with sinus rhythm.
late diastolic murmur.
MS with sinus rhythm, there can be late diastolic murmur. The same conditions which I mentioned in mid-diastolic, but in sinus rhythm. MS with sinus rhythm, TS with sinus rhythm, LA or RA myxoma, complete heart block. In complete heart block, it should occur in the late part of systole, diastole. Continuous murmur.
PD or aortopulmonary.
Aortopulmonary window without hypertension. PDA without pulmonary hypertension. Or the surgically created fistula, AV fistula. Venous sum is a closed DD. I won't go into the details of venous sum. You can read it by yourself. Okay. Last 2 minutes. Dynamic auscultation.
Okay. Break. சொன்னாலும் சரி சட்டு விட்டு ஒரு 5 நிமிஷத்தில் விட்டீங்கன்னா
Okay, dynamic auscultation. We have 5 maneuvers. First I told you. One is positional change. Respiration itself is a dynamic auscultation. Valsalva maneuver, Muller's maneuver we are not going to do. Isometric hand grip is there. Amyl nitrate drug we are not going to discuss.
Valsalva and
I'll tell again. Positional change, respiration, Valsalva, isometric hand grip. Okay. First we will finish respiration. Very easy. Inspiration increases flow. So all murmurs increase with inspiration. All murmurs
increase.
All right-sided murmurs increase with inspiration. All left-sided murmurs increase with expiration. Okay. Now, mitral valve prolapse and HOCM both are left-sided murmurs. These two murmurs are very exceptional. Mitral valve prolapse produces a late systolic murmur, which is followed by a click. HOCM is a subvalvular AS, which can produce a aortic stenosis murmur, a mid-systolic murmur in the aortic area. So, in conditions where all other murmurs decrease, these two murmurs will increase. Just remember this basic. You can read the mechanism somewhere else. So the place where all other murmurs decrease, MVP murmur, the late systolic murmur of MVP and the mid systolic murmur of HOCM both will increase.
Okay.
Vice versa. Just remember this basic. So in inspiration, right-sided murmurs increase. In expiration, left-sided murmurs increase except
HOCM and MP.
Where it reduces. That's all. Reduce in MEP we have to say the murmur shortens. Okay. This finishes inspiration and expiration. Now coming to the positional change. If you are standing, what will happen? Blood flow to the heart will reduce. It gets stagnated below. So standing will reduce the murmur. Squatting will increase flow. Passive leg raising will increase the flow. Lateral decubitus position will bring the heart in close contact with the chest wall. So small murmurs. Wait, I'll come one by one. Left lateral decubitus position, there is no flow change. We are just bringing the heart closer to the chest wall. So
அந்த பாயிண்ட் எழுதிக்கிறீங்களா? Heart rate increases.
This is the actual reason, but remember like this. In left lateral position, heart comes closer to the chest wall. So small murmurs like MDM and S3 gets aggravated. So you will tell in MDM, right? It is best heard in the left lateral position.
Yes.
Because heart comes closer to the heart. One is over. Sitting and leaning forward position is the position where you hear AR and PR. This is just basics. Because aortic root and pulmonary root will come closer to the chest wall. That's all. This is just positional changes based on the proximity. Left lateral decubitus, LVS3 and MDM. AR and PR is sitting and leaning forward. I told you initially, split can be confirmed finally by sitting and legs dangling. Okay.
Yeah. Legs dangling was
like this. கால் தொங்கிட்டு இருக்குது. Okay, now coming to the last important one. Squatting followed by standing. I told you standing reduces flow. Standing reduces flow.
Yes.
Except
HOCM.
That's all. Squatting will increase the flow. Except
MVP and HOCM.
that's all. Okay, leave off this hyperextension of shoulder because I didn't tell you that. Okay, passive leg raising will increase flow. So it will increase S3, it will increase MDM, etc. Knee elbow position is a friction. We have finished 2. Valsalva that day we are discussing, right? So how to do Valsalva? Just note that. One, give him a sphygmomanometer, ask him to blow for 10 seconds to 40 millimeters of mercury manometer. Or blow with closed mouth and nose for 10 seconds. Or give pressure to his abdomen and ask him to resist against that. These are 3 methods of eliciting Valsalva.
Okay.
Right? Easiest one is blow a manometer. We have 4 phases. 4 phases you can read. Initial phase, what happens? We are straining. Leave off phase 1, leave off phase 3. Because clinically detected phases are phase 2 and phase 4. What happens in phase 2? Intrathoracic pressure rises, so venous return decreases. So BP reduces, heart rate increases. What happens in phase 2? Increased intrathoracic pressure,
Your
return.
Okay.
Increased intrathoracic pressure, venous return decreases, so BP reduces, pulse rate increases.
Where is intrathoracic pressure?
That is self-explanatory.
Right.
Increased intrathoracic pressure, decreased venous return,
That is
decreases BP, increases heart rate. So any flow decreases means what will happen?
HOCM MVP increases.
That's all. Phase 4 is the straight opposite. When you are releasing the valsalva, intrathoracic pressure reduces. So venous return increases, pulse rate reduces. Again the same thing. When venous return increases, flow is more. All murmurs increase except HOCM and MEP. That's all. Now
This phase 4 is what happens? The pressure releases.
Pressure releases. So intrathoracic pressure becomes normal. So venous return will increase. Okay, this is all you have to know about Valsalva. How to do Valsalva? 3 maneuvers. How to interpret? Phase 2 and phase 4 are only clinically detected. Okay, last one. 2 and 4. I didn't discuss the other things. We can have it in some other session. Now coming to the last one, isometric hand grip. If you are doing a hand grip, what happens? Systemic vascular resistance increases. So aortic pressure increases. When aortic pressure increases, aortic to LV gradient increases. So AR increases. So MR increases. So AR murmur, MR murmur increases. When those two increase, what will happen to MVP murmur? It shortens. Same mechanism.
AR increases.
Peripheral vascular resistance is increasing. So aortic LV gradient is increasing. So MR will be more, AR will be more, MVP will be less.
Reverse.
HOCM shortens.
Okay.
Same thing, MVP and HOCM is the reverse, but just remember 2 things. AR murmur increases, MR murmur increases, S4 accentuates. So this completes our entire auscultation session.